get to it. So FDH stands for frictional dental hypersensitivity. NOS stands for neural occlusion screening. Thank you again, Dr. Piper. And thank you again, Dr. Piper, for Anomalous Medical. There's a software program that his son Andrew created based on algorithms, based on Mark's experience over the years as to what he saw surgically, what the disc, the soft tissue components did to the occlusion. And I have to make a quick disclaimer. We work with Bio and TechScan, Bio Research Associates and TechScan sometimes. I use a lot of their gear because I'm really big on quantifying things. I love what I do, but he's right, I would be fishing if I had the choice right now. It's that time. Okay, I practice in Rogers, Arkansas. I'm a GP. I've been there. This is Walmart corporate headquarters. I've been there since, 2015 July, so right at 3 years. 80% of the time, I'm a general dentist that does all kinds of high-tech stuff like CAD/CAM, using EMGs, etc. 20% of the time, though, I dedicate that amount of time to specific orofacial pain. But I'm 100% of the time thinking about occlusion. Because, think about it. What are we supposed to be good at? We're dentists. But the sad part is gums, teeth, and bites, right? I hate to say it, but most dentists don't understand bites. And we're going to get to that later in the lecture. We're not taught. It's not our fault. So back in the day, I was a Texas A&M student, and I was an engineering major, aerospace. That's how I started out. And I changed my mind about 2 years into it, not because I didn't like it, but because I came from a family of a bunch of physicians, and the medical thing just was too powerful. I was pulled that way, so I went dental instead, because I want to work for myself. So I love putting numbers to things, all that calculus, okay, and ingrained that in me. And I'm here to make this topic practical. Dr. Piper peeled our eyelids back, and I'm here to make it every day. So let's watch a quick video on a patient. Now, this is not a fly-in. You guys don't know this yet, but I see people from literally every continent except for Antarctica. I don't know how many hundreds, we lose count. 20% of the time, right, we have a huge outreach from our videos and our publications and what have you. But I'm going to show you, this is a local patient. This was not someone that flew in to see me. She lives in Northwest Arkansas. It actually works at Walmart corporate, and I'm hoping the audio works here. What would you like other dentists and physicians to know about this?
So much.
Is this disconcerting to you, the fact that nobody knew?
It is. I also recognize that it's different. It's hard. I knew I wasn't crazy, but I felt a little crazy. To have pain that's jumping and that you have this flushing and this weird sweating. These things that don't feel like they should be that impactful in your life, but they really are. The psychological toll that it takes on a person is great.
Probably even your family have a hard time believing it, I'm guessing. That's the tip.
It's hard. They were understanding, but I think because they saw the pain in my face, there's just something about looking somebody in the eyes and going, something's off. What helped, I think, my family is a family friend who has trigeminal neuralgia. Right. And so she was providing insight saying, no, it's really this bad. Hey, it's really hard to diagnose this. I think without her, it would have been harder to convince them.
Sure.
I feel really lucky in the sense that I didn't have to have an extraction, that I didn't do multiple unnecessary root canals. I read about people who have to have so much more done before somebody says, maybe this isn't that. So there's something good there. But asking questions more than just assuming or jumping to a procedure.
Let me give you a quick example. Yesterday I had someone that drove in. He drove in from, I don't remember, it was Georgia or Alabama. Mm-hmm. Beside himself. Long story short, we scan him, we look at the MRI and the CT.
Joints are a little tore up, but not bad. That doesn't warrant a Piper referral, but all of a sudden I start picking away the layers and I start asking the right questions. And guess who's a CRPS patient? Likely. I can't make that call. I'm not qualified to make that call, but I know just enough to be dangerous. So the only place I can really send him is to Piper. Dr. Piper, you know, maybe I missed something on the joint, maybe that's a contributing factor. You know, so my point is, I see this stuff probably once a week. But I see people from all over the world. It's an unusual practice. You know, in the normal patient pool, I will tell you, I would say 2 to 3 times a year. At least that I'm not catching every one, of course, I'm sure there's more. But in my normal, hey, there's Dr. Nick Yiannios in Rogers, Arkansas, patient pool.
Yeah.
I've heard he does some really cool things with lasers and CAD/CAM and, you know, all this, you know, beautiful cosmetic stuff. That normal Dr. Nick stuff, 2 to 3 a year. And I'm sure there's more there that I'm not recognizing. So my intention, like with this video, is to people like you and me try to get this out so people like you don't have to go through this kind of BS just to get a freaking diagnosis, excuse the language, right? You know, because you're not crazy. And it's like, it's really sad.
There were moments where some of the doctors, I knew I believed Piper. I still believe Piper. But when you hear no so many times, you start to think, did I buy snake oil? You know, should I trust Piper? And even though I know that's where the education and the expertise lies, it's really hard to come back with this treatment plan you're so excited about.
And then he gets shot down because they all said that he's incorrect.
He's incorrect. And it's really disconcerting that people aren't even open.
I'm not an expert. I know. I'm not an expert, but let me tell you something. Piper's taught me that the longer the block lasts, in other words, if you just get a few hours on stillate, that's not a good sign. The longer it lasts, the better the outcome. In other words, you're more likely to go into remission.
Yeah.
So if you got more than just a few hours out of that, right, thumbs up. I'm hoping you get months or weeks.
Me too.
It's probably going to slide back, but now you've got a place to go.
Yeah.
You know, and maybe I'm not, but I don't know that there's a cure for this, so to speak, okay? Nobody really understands all of it. But all of a sudden you know what's wrong. You can manage a disease if you know what's wrong with it.
Yeah.
And I've read a few reports in literature, the research that I've done, where the authors claim the patient was cured after stillate ganglion declines. Now, define cure. 5 years out? A year out? 6 weeks out? I don't know.
And that's some of the questions that I have because
Yeah, I'll try to get to you.
for me, I want to get off the pills.
Yeah, right.
You
You're
know,
still on some?
I'm still on the Tegretol and the gabapentin because
Did they not put you under the Lyrica?
no.
Didn't? I thought Piper was pretty big on Klonopin and Lyrica.
So I couldn't find anybody that was willing to add the Klonopin. And
I'm not qualified for
no,
pathology.
yeah, my general physician didn't want to be the one to add that. He was like, that really needs to come from one of the pain doctors. But because all the pain doctors were telling me no,
Sure.
I never had an opportunity. And so then when we went to this doctor who did the procedure,
Maybe you can start going back to him.
maybe we can start. I've got to follow up with him in a couple of weeks.
Yeah. This experience in his world will help him identify dozens, if not hundreds of people like you over his career. So we just made a big change there in the area. No, 30 years. That's cool. Yeah.
I mean, it makes me teary-eyed. It really does.
Good stuff. Give me a high five. All right.
Okay. Sorry, guys, I'm gonna have to flip through. All right. So 9 tools that I can't practice without. This gives everyone an idea of what it is that I do every day. I'm really big into CAD/CAM, have been long before it was fashionable, about 12 years now. 40 micron tolerances, notice the number. I don't have to send off to a lab and have aberrations, distortions, impressions, and what have you. If you really know what you're doing with CAD/CAM tech, you can replicate what it is you need to replicate. We put a number to it. T-scan. Who in the audience uses a T-scan? Great. As we all know, the users, we can put numbers to things. We'll talk more about that later. Joint vibration is a screening tool, not as a definitive marker, but as a screening tool. Who uses that? I use that on every patient, have for many years. Electromyography, I use the bioresearch because it syncs with the TEC scan. Anyone? CBCT, I use it for dental. Yeah, raise hands. How many we got? Great. I use it for the dental application, but I also use it for the joint application. And it's amazing what we skip over because we just don't know. We weren't trained, right? And oh, that's the radiologist should do that. That's his purview. And yes, it is, but the med radiologist botched it up. I can tell you that from experience. Dr. Piper will tell you that too. How about the MR? How many people in this audience shoot MR routinely? I do 2 to 3 a week on average. And I, yes, interpret myself. I'll always read the medical radiologist's scan, his report, but I won't trust it most of the time. And he's a good friend of mine. And we'll laugh over a beer and he'll tell me when he's drunk, yeah, my brethren, my profession, my peers, we miss the diagnosis 40% of the time statistically. And they have no training in regards to this joint in particular. They shouldn't say that. I'm not going to get too deep into that world, but Dr. Piper and I, maybe we can talk about that later this afternoon. Anomalous medical, I use it constantly. My hygienist, Boone West, is sitting in the front row. How often we use it a day, Boone? How many?
A couple times a day.
At least 2 in hygiene. In hygiene, to educate patients. Thank you, Dr. Piper and Andrew. Digital photography and videography. And ice water. Who here uses ice water in their practice? This is invaluable for me. And I'll get to that. So, everyone likes a story, once upon a time. Who's heard of DTR? Exclusion time reduction therapy? Kirstein? Does this ring a bell? Who's heard of measured anterior guidance development? Measured anterior guidance development? Who's heard of frictional dental hypersensitivity? Who here has patients with sensitive teeth? Come on. Everybody, right? Correct? Who's heard of brainstorm and answer? The odontoblast transducer theories. Does this look familiar? If it does, raise a hand. All right. Force and time, putting numbers to it on the left side of the screen. Muscular activity concurrently in 3,000 a second increments. Another quick video.
Yesterday, on a scale of 0 to 10, what were you?
I was at a 7.
7. 10 is horrible. You were 7. What are you now?
3. Just because I don't like ice water, but
Yeah, but it doesn't hurt anymore,
it
does
doesn't
it?
hurt.
It's like normal.
Right. That is remarkable.
Pretty cool, isn't it?
That is amazing, yes. I can drink. Does it bother you? No. Wow.
Drink cold water now?
Yeah.
And with ice, I never drink with ice.
Because hypersensitivity to teeth, not to cold.
Actually, I intentionally ate a fruit bar.
Yeah,
No,
no problem.
no problems.
Whereas a week or 2 ago, if you had done that, you had a problem.
Yep, when you gave me the ice water to swish around, I had certain sensitivities
They're gone.
gone.
Ice water, see what it does. Yesterday, what was she? She was a 7 out of 10.
I don't have any sensitivity. Like, I drank iced tea today, hot coffee. It doesn't bother me at all.
Nothing. Okay. Try it again next year. Switch to an ice water. That's all good?
Yeah, I mean, like I said, maybe a 1 compared to like the 7 before. Like I'm not having the zinging that I normally have down there.
I mean, really swishing around. Do you feel any sensitivity?
It's a trip.
What do you feel?
It's
Zero to 10.
very, very slight.
Well, it's supposed to be a little bit, right?
Time for a cold beer.
Sorry. Did you say it's like a 1, 0, or 2?
Probably a 1. I'm not enough to even bother me. That's remarkable. I like that. Wow,
For you.
awesome.
Told you to do this. 0 to 10.
0.
0.
That is amazing because I couldn't stand ice water.
An hour ago.
Yeah,
An hour ago, what was that? You said a
it was a 6.
6 out of 10.
Yeah,
10's horrible.
yeah,
And now it's a
it's 0.
0.
That is amazing. It's amazing.
Hypersensitive teeth are a sign of muscular TMD issues. Your muscular TMD issues are fixed.
Yeah,
Your hypersensitivity has gone away.
and it's not dynamic.
This is back when I was a dentist. Now I practice more dental medicine than I do dentistry. Because I would call this is 4 years ago. This collage was put together 4 years ago. I would call this an allodynia. Because we need to talk the same as the medical guys. If we don't, the patients get lost in the shuffle, as Dr. Piper alluded to. So way back in the day, almost 10 years ago, I ran into Kirsty. I was on the board of directors of the Academy of CAD/CAM Dentistry. Before Scottsdale, everyone ever heard of Rich Masick? Rich Masick was kind of the guru of CEREC back in the day. And I was one of the 5 or 6 guys that ever got credentialed in his org. And I ran into Kirsty in one of our meetings, and this occlusion time reduction thing, I picked up on that because he's throwing numbers to the occlusion. I knew something was, I was doing these beautiful little CAD/CAM pearls, if you know what you're doing, but the bite was off sometimes, or their teeth were sensitive. And I'm like, that's not good enough. I'm putting numbers to things now. I've got a superior fix to a lab-made restoration if I'm doing it right. Why is it off? My margins are better. It doesn't make sense. I'm cutting less away. It doesn't make sense. So all of a sudden, I'm starting to apply DTR in my practice, and I'm noticing that their cold sensitivity is going away. The ports from the handpiece are blowing water on their teeth. And by the end of the procedure, they're starting to lose cold sensitivity. So about, 8 or 9 years ago, 7 or 8, sorry, I start pulling out ice water on every patient. Periodic exam, comp exam, toothache, you name it. Trying to get an idea of let's see what happens when I jack up the numbers. And I start playing with a T-scan and start integrating Robert's concepts. So Robert and I become pretty close, and Robert one night breaks down in tears, and he's a pretty stoic guy, and he's crying, going on about how no one's really watched his publications for 40, 50 years. And he was happy to tell me, though, that he had just been sanctioned to write the world's first textbook on digital occlusion. He asked me to be a co-author, and I said, sure, why not? Actually, I didn't say that right away. I was cussing at him because I don't have time for that. I'm a busy GP wearing scrubs. So I put together a pilot study on the frictional dental hypersensitivity concept that I named it. I spent over 15 months researching literature, references, looking for reasons why. I couldn't really find good reasons. All right, I was going through all the TMD, the CR, the splints, the neurology. Remember, I'm not an academician, guys. I'm a GP. I practice just like most of us out in the audience. And I'm looking at the literature. Back in the day, I was a little more, what's the word? Ignorant to the fact that just because it's written doesn't necessarily mean it's correct. I was looking for the cold explanation, couldn't find it. Studied over 400 sources, front to back. Came up with a pilot study, published in 2015. We staticized 34 patients. And they were all proven, their cold sensitivity went away. It was statistically relevant. We did a formal study the following year. Kirsty and Radke helped me with that. I put 100 on. Same thing. And then we had it republished again last year in another textbook. And we're working on the second edition. I'm working on that this month. And Dr. Piper is actually contributing to this second edition of the textbook too. So the FDH research summary, what the heck is this thing? Well, a 5-second ice water squish, by the way. Muscle flexes teeth, interpulpal and periodontal proprioception, trigeminal and autonomic. Okay? We're all taught trigeminal. It's all about the trigeminal. What about the autonomics? What about the sympathetics? And then if you start going into the literature, you're going to see all these references to the parasympathetics. As Dr. Piper pointed out, cranial, sacral, right? Thoracic, lumbar. Well, he showed you the anatomical pathways. The reality is the sympathetics are in play here because they're vasoconstricting. Excessive flexure. Now this is old theory, okay? This is what's published from me in 15. So it was written in 13, 14. Excessive flexure leads to decreased cold perception threshold. So you flex a tooth too much, the threshold whereby they perceive the cold, or the allodynia, is decreased. You decrease the flexure by efficiently reducing the muscular output. You increase the threshold whereby they perceive the cold. How am I measuring this? With T-scan and EMG. I'm putting numbers to bite, I'm putting numbers to muscle in 3,000th of a second increments. How many times do you time someone's bite? How many times can you put a number to the muscle? Okay, we're all using ink ribbon, think about it. I want you guys to think of a quick analogy. Typewriter, Microsoft Word. If you're using ribbon and ribbon only, you're on typewriter. If you're not putting a number to it, objectively and digitally, you're not on Word. Which is more efficient? Teeth were found to be less cold sensitive when you precisely measure and control the muscular output. We had electrodes over the temporalis and the master, bilateral. So, as Dr. Piper mentioned briefly in his lecture, we've got the A delta myelinated, right, nociceptive fibers, intrapulpal and periodontal. We have the C fibers, unmyelinated, slow. You guys remember this? We all learned this in school, right? Raise a hand, come on, I want to see it. This is what I remember they taught us in school. But they never, and Dr. Piper mentioned this, who heard A beta in dental school? I did. If you did, I'm glad. I'm surprised. That's great. The A beta is something different. The med students studied that when they were in their other building. I don't know where you guys went to school, but I assume it had a medical and a dental component. They were learning about A beta because of skin and what have you, right? Proprioception, the canoreceptors. Well, think proprioception. So this is written around 2014. This is what I published back then on that novel theory about cold sensitivity, which is a dental allodynia. About that time, I'm starting to pull away from Dr. Kirstein. Love him, we're still good friends, but I'm like, there's got to be more to this. I'm seeing great responses, but not what I think I need to be seeing here. It's too haphazard. I'm not diagnosing the patient properly. So, how many times have you got a report back from your endodontist? I had one 2 days ago. Patient needs a root canal. Well, why? What's the diagnosis? Well, they just need a root canal. Why? Irreversible pulpitis, for one thing, really, is that all that's going on? So think compartment syndrome. Dr. Piper went into that in great detail. We'll get to that later. I seek Dr. Piper out. Did you guys know he used to be in the Dawson Academy? He was kind of politely pushed out about 10 years ago because he confused the students. He was at the end of the curriculum. All right? This man needs, you guys need to listen to what he's saying. The Piper Education and Research Center, he's had this little teaching institution going for, I don't know, Mark, 8 years? 10?
I think 59.
Oh, I'm off. Okay, well anyhow, I went down to St. Pete and started learning from this guy. I started learning how MRI and CBCT wraps into general dental world, and endodontics, and periodontics, and prosthodontics, and oral surgery, etc., and pedodontics, and orthodontics. I started learning about his concepts of joint-based occlusion, which I was never introduced to. At this time, I'm about 45. So I'm quite a number of years into this game. All of a sudden, for the first time, I'm shown how to put numbers to the discs and how it matters anatomically if you're dealing with lateral medial pole. I know what lateral medial is, but I never thought of the disc as mattering if you're on one side or the other. I started learning about how to quantify the hard tissue, the bone, up in the joint, not just the teeth. Because remember, I'm becoming less of a dentist and more practicing dental medicine at this point. I'm starting to learn about sympathetic inputs. Cervical inputs in surgery. Oh God, I've lost, my patient's going to surgery. No, actually, there's times that I would put my family member on that table with Dr. Piper if indicated. If the numbers point to it, that's exactly what they need. So how do you influence an industry? How do you get the word out there? I'm a guy in scrubs. Maybe 2 times a year I'm out somewhere like this. Well, get online. You know what you do? You jump over everybody because the academians won't listen. What you do is you go to the patient. That's the end user. And you start throwing information out there to give them hope. You give them hope because someone's looking. And you start seeing these confounding patients that have been literally everywhere. I don't know how many times I've heard Mayo or UCLA Dental School or Harvard, whatever. It doesn't matter where I don't care if they came from Europe, Australia, Asia, seen that many times. Haven't seen Russia yet? China? I've had emails from Syria and Iraq, by the way. Quite a few. So you start a YouTube channel. I did this about 2000, I don't even remember, 11, 12. There's over 150 case studies up on the YouTube channel now. Dr. Nick Yiannios, type it in. You could spend dozens of hours. I've literally spent thousands of hours on this, on the video aspect of what we do. You can also find me on ViewMedi, V-U-M-E-D-I. Has anyone heard of ViewMedi in this audience? It's the YouTube for physicians and dentists, and it's free. Okay? There's some serious stuff on there. Dr. Piper and I and Dr. Alfred in the back, we three did a ViewMedi webinar back in January. You guys can, it's archived, you can look at it. All you have to do is register. So, another quick one. This map is old, by the way.
So tell me, where are you from?
Ireland, Chicago, Pittsburgh,
Colorado, Missouri,
Canada, Germany, Colorado,
Los Angeles, Calgary, Alberta,
Upstate New York,
the Bay Area,
Texas,
Memphis,
Minnesota, Florida,
Tennessee,
Saudi Arabia, North Carolina,
Illinois,
Nevada,
New Jersey,
Turkey,
from Spain,
Missouri, from New Orleans, Canada.
Indonesia,
Indonesia?
Australia.
So define a disruptor for me.
The disruptor is the innovator, the person in an industry that doesn't follow the norms and goes, out of the box thinking, and so disrupts the normal course of events.
I wanted a dentist who looked beyond just the teeth.
What is it?
Think of 7,
Okay. Doesn't linger, does it?
just a little slightly on the back,
Back right or left?
right?
Love that ice water squish. Okay, so it's been, what, 24 hours?
Yes.
Almost. How do you feel?
I feel better. My bite is definitely different, but it's a good different. When I close my lips together, my teeth aren't clenching down on each other, so it's a little more relaxed.
Yeah?
No headaches this morning.
Do you typically have headaches?
All the time.
All the time. So this is exceptional. None?
Nothing at all. Wow. Nothing.
So what do you think?
It worked. That's awesome.
How cool is that?
Yeah, that's cool.
So you glad you got it done?
Yes.
All right. So the YouTube channel, quick screenshot. This was taken back in April. We're close to 1.4 million views, 4,300 subscribers coming up on. This is all in the PDF. Right? There's some serious stuff on there if you guys want to watch it. There's some sillier stuff, but there's some very serious stuff on there. We get 2,000 views daily on average. So I'm reaching out to 2,000 end users every day. As we speak here, another 2. 1 to 3 subscribe to the channel every day. If any of you have younger kids, my son's up here, he dreams of being a YouTube star. It's hard to do that. So it's interesting, people only spend about 2.5 minutes on average. You guys see that, average view duration? So we start thinking about marketing. But the reality is in the industry, you're lucky if you get 20 or 30 seconds, but we're getting 2.5 minutes. There's a difference there, factor of 5 or 6. People are interested. So I start getting all these emails and phone calls and contacts. Who in my area does this from the patients? And from the docs, how do I learn how to do this? I've never seen what you're doing before. I've never even heard of this. What is it you're doing? So I start a network, a teaching institute, a little thing, because I don't have time for something big. We call it the CNO, the Center for Neural Occlusion. Website's on there, you guys can find it in the PDF. And what am I doing? I'm trying to address the patients. I'm trying to find a way to help them find a doctor. Someone that kind of at least has seen what we're talking about. And there's about 6 or 7 people in this audience that have been through the CNO curriculum, at least parts of it. Some of them through all of it. Right, Terry? So who are we? We're a bunch of guys. Who's the guys or gals? We're a bunch of professionals. Doesn't have to be a dentist. Presently, we're the board of advisors. We're primarily dentists, oral surgeons, etc. But we're looking to pull in physicians, neurologists, chiropractors, physical therapists, naturopaths, you name it. Why is that? Because the TMD world crosses many boundaries, as Dr. Piper very eloquently described earlier. So the board of advisors, we've got, I think, 4 or 5 of them sitting in, including Dr. Piper, Dr. Fargo, Dr. Alfred, right? Who else am I missing? Alan, where are you? Sprinkle, yeah. GPs, oral surgeons, radiologists, orthodontists, prosthodontists, periodontists, and industry members. So what's the point? Well, we proffer that imaging matters. We proffer that putting numbers in things matters. Measured matters. That's our motto. Our mantra, proper diagnoses, plural, it's almost always plural, not irreversible pulpitis endodontist, for example, could be, may not be, precedes responsible treatment. I use the endo example because it's classic, we all hear it every day. How do we do this? What's the method? Objective tools. And we're always looking to add more. Thank you, beam readers, for existing. Thank you, Dr. Hatcher and his nephew back there. Love Tom. So, what's the thing with the seeing on the perk? Well, we're kind of a bridge to Dr. Piper's world. We kind of make it practical and introduce you guys and make you guys realize that he's alive and well and teaching. And we do some stuff too. So, what do we share though? We want to protect the patients. As I mentioned earlier, there are times when that patient is far, far better off with a surgical intervention than something else. And that's not saying lots of people need surgery. What I'm saying is there are times that we should, as the quarterback, identify that that could very well be the best course of action. So here comes the rub, and I've already mentioned it. We're supposed to be experts at the teeth, the gums, and the bites, but we often fail at the occlusion. Because that's what we're taught. Now let me show you guys why using anomalies. Dr. Piper's software.
The left TMJ is illustrated. Blue means all tail touching. This is the cartilaginous disc. There's a lateral and a medial pole. The sagittal view. Notice the posterior band of the disc at 1 o'clock. Notice as we change the cartilaginous disc to 12, 11, 10, 9 o'clock positions, how things change in the glenoid fossa. Returning the disc to 1 o'clock normalcy, look how things change back again. From a distance, watch how tearing the cartilaginous disc changes the occlusion. Blue means touching, white means not touching. The anomalous medical software does a wonderful job displaying the changes that a bite may undergo results into backside joint changes. Leaving the left side TMJ at 9 o'clock, now we move to the right side and start tearing cartilage on the right side TM joint. Notice how the occlusion changes even more. And the back teeth are constantly contacting. Notice the front teeth are not contacting when both joints have a 9 o'clock positioned disc and anterior open bite. This is very important. Changes in the joint rarely affect the occlusion. Now the anomalous software will demonstrate for us what tearing cartilaginous disc on the lateral aspect only will do for a patient's occlusion. A left-sided lateral pole 12, 11, 10 o'clock tear. 9 o'clock. Notice how all the teeth on the occlusal level look normal, even though the lateral aspect is torn. Without MRI, one would never know about these torn cartilaginous events.
We introduce the imaging. Then we push people to the PERC to take Dr. Piper's imaging course. So we're high school, he's college when it comes to that. So how many people in this audience have patients with anterior open bites? There are ways to look and decide if you need to scan. You probably should. There's things that we can look for clinically, and that we can put numbers to, and that we can objectively observe to indicate how many people in the audience take MRI because of an anterior open bite, fairly routinely. Not to say all the time, but I do. There's reasons for that. It's huge. So lateral and medial pole makes a difference. The Piper classification, if you guys maybe just buzzed over your head, it's based on this premise. It's based on the position, condition, degree of herniation of either lateral or medial pole of the disc. It's huge important. 25,000 TMJs, 7,000 have been open. I think this guy figured out at about number 100 or so what the MR looked like, right? So, and here he is, 30 plus years into his career. Piper classification is how he practices in his clinic. I watched it many times. We've shared dozens, if not hundreds of patients together. So I see the scan, the interpretation after this guy, he hones my skills. Literature facts. Over a third of asymptomatic patients have TMJ internal derangements. Over 1/3 of the people that we see have internal derangements, whether we like to know it, or think it, or believe it, or not. This is in the literature. And by the way, nowadays, as I practice more dental medicine than dentistry, I'm more into the radiology literature, oral maxillofacial surgery, the medical literature. So greater, it's actually much greater, I'm sure, than a third of all patients. And I will even extrapolate, maybe this will raise some eyebrows, but I think much of the extensive dental work that's done on this planet is resultant of torn intercapsular issues. Soft tissue things, they go completely unidentified. You can't see that with the CBCT, you can only see spacing. You can see sequelae of a history. You can see the past and the present, but with the MR, the only way to predict efficacy is the MR. You can see present and future. So almost 90%, think about this, of symptomatic patients have TMJ internal derangements. And if you're not shooting MR, in my world, you're one of those patients that walks in, flies in, drives in from wherever, and I'm rolling my eyes because they never got scanned. Or if they did, the dentist just relied on a radiologist report. Can't do it. Medical. So almost all that hurt have derangements, 90% in the literature, the radiology literature. So how we usually get away with this, right? A large percentage of deranged joints adapt is huge, and remain the same over passing time. This is a living system, correct? 91% maintain the same joint status at 15 years. Radiology literature. So TMJs and occlusions matter for every single practice, every age, every day, tomorrow, last week, a decade ago, 100 years from now. All these people have joint problems. Cool thing is, nature adapts us much of the time, most of the time. That's how we get away with it. But you know what? Here's probably one of the most important general statements in the entire lecture. The TMD world crosses many boundaries. It's an all-encompassing, it's a term. I mean, what does it mean? It means nothing. There's nothing specific there. It could be 90 or 100 different things. And here we are as dentists thinking teeth, muscle, airways, spacing. We're not looking at the joints. We're not looking at the soft tissue. Now, we're looking at tongues, we're looking at this, that, and the other. We're throwing EMG leads everywhere. We all have our own take. We don't know what we don't know. So what's the point of the CNO? A network to link together health professionals. As we grow, we're going to bring in more and more. Crosses all these boundaries and more. And remember, 2,000 views a day. Get the end user to demand this. Nature can care less about boundaries. Can care less about licensures. The more I know, the less I know. I'm not sure who wrote that, but I love it. Because I'm dumber now than I've ever been. The more I learn, the less I know. Because I realize how big a universe it really is. I do know this, though. I know that measure matters, and I know that I have to put numbers to things. Absolutely have to. Okay, so when I'm sitting there screening patients, by the way, when they come in for wherever, for the 20%ers that come for TMD workups, orofacial pain, whatever you want to call this, first thing my hygienist Boone will tell them is he doesn't want to know why you're here. That's the very first thing we say. We rule out odontogenic, periodontic, things like that. We're looking for tooth gums, the normal stuff, the normal dentist missed, the full comp exam, get them ready for an MR and a CT, and then I run them through the second day what's called Neural Occlusion Screening, NOS, the title slide. Neural Occlusion Screening encompasses all these modalities that we're presently using to put numbers to things. At the end of that screening, which takes about an hour and a half, in which I share all that data with the patients, I walk them through Anomalous, which you guys have seen. I walk them through their MR, both sides, their CT, etc., their T-scan data, their EMG data, all these other things that I'm not going to have time to go into. The end of the appointment, an hour and a half or so into its second day, I look at them and I say, now tell me why you're here. Trauma history, accidents, all these things I've alluded to. Now, at the end of the day, now you tell me why you're here. Because I don't want the subjective BS. I don't want to see a bag full of splints dumped on the table. I don't want to hear that Dr. So-and-so, whoever he may be or she may be, said this, that, or the other. I could care less. I want to put numbers to stuff. And this is what we do. This is what we're trying to proffer and what we're trying to teach with CNO and with the PERC. Dr. Piper's doing an awesome job with the PERC. There's layers, man. There's all these different layers, and we're just dentists. We can only do so much. So that's important. So I'm only going to talk about a few layers. There's dozens. There's scores more. The timing of the occlusion, it does influence it. I've been doing that for 8 or 9, 10 years now. I can shut off people's hypersensitive teeth much of the time. Shut down their allodynia. Why is that? Is it trigeminal? Not so sure about that. I think it's autonomic. I think it's a combination of both. I'm not an academician. I'm not a neurophysiologist. It's not what I do. But I can tell you what I see clinically, and I see them from everywhere. So it's a layer. Trigeminal inputs, they influence things. Of course they do. We see it every day. We treat that all the time. It's a layer. Cervical sensory inputs. A bunch of us, this audience, I'm sure most of us think that way too. But who here's doing neck blocks routinely? We all need to learn, at least the greater auricular. It's a layer. It's how you diagnose, guys, how you have a differential put together. You eliminate one nociceptive input after the other. Sympathetic inputs, those influence TMD and occlusal issues. Dr. Piper spent 2 hours on that. A layer. Timing, what am I talking about? So what is immediate complete anterior guidance development? This is Dr. Robert Erskine's theory. They started writing about it in about 1989. Immediate complete anterior guidance development. Now, this is dental world. We're just talking teeth. Joint, teeth. In my world, in Dr. Piper's world, many of these people in the audience's world, sure, maybe everyone's world, we've got a 3-legged table, correct? If you shorten one of the legs of the table, does it wobble or not? This is a biomechanical thing. Is there a thickness to the cartilage? Does the thickness vary? Is the posterior band thicker than the intermediate zone? And then is the anterior band kind of intermediate? So you've got a shim and a hinge, and as you tear things out, it alters that spatial relationship. And guess what that does directly to the mandible? It alters the way the teeth, which are connected, hit the jamb, the maxilla with teeth connected. Now, what if we had all kinds of neurology in there? What if we had all these things going on that no one really completely understands, and we're starting to fire up muscle? Or maybe the genesis is cervical. A quick blurb. As I'm writing for the second edition, the new update for the chapter, I found a literature reference, I can't quote it off the top of my head. Superior cervical ganglion, axons sitting in the superior cervical ganglion, which have their end fibers in the pulps of our teeth. I want you to think about that. You've got this little spider web making its way up from the neck into the teeth. They didn't teach me that in school. They teach you that? I didn't get that. They kind of mentioned haphazardly that we've got intrapulpal and periodontal blood flow and a vasculature, but never any detail. And then if you get deeper into the world, you hear about neuropeptides, neuropeptide Y, CGRP, substance P, bradykinin, right? What do all those things mean? So, this guy on the left, the Indian guy, Prafulla Thamadi, myself, and Dr. Robert Erskine, we're the guys that have published on the ICAGD thing, basically. I'm going to run through this slide quickly. We don't have a lot of time. So Robert calls it disclusion time reduction therapy. So there's Batman with the stripes, the horizontal stripes. And I was Robin back in those days, okay? Nowadays, I left the Batcave and I'm someone else. I'm Nightwing, if you guys followed the comics when you were a kid. And I'm trying to tell Batman, hey, there's better ways to predict efficacy. But he's a dentist, he doesn't want to think that way. So here I am. I've got about a dozen friends out in the audience, and I'm hoping I'll have 100 more by the end of this talk. Because I want you guys to start spreading the word and start thinking about it. Maybe you'll just put this in the back of your mind. So here's Robert's original theory, published, I think this was like 90-something, or the original DTR theory, basically too much frictional rub on posterior teeth, not anterior, ramps up the CNS, it's talking trigeminal inputs only, you got this perpetual cycle, too much lactic buildup, muscle pain. So what do? You decrease the excursive rubs, not the centric, not the closure. It's this stuff, the timing on these back teeth. And you can see it with the T-scan in 3,000 millisecond increments. And you can actually slave that to electromyography so you can see what masseter and temporalis bilaterally are doing in 3,000 millisecond increments. Now this is Robert's whole theory. And honestly guys, for many, many patients, this will serve you extremely well. The video that you saw with the people, the cold sensitivity going away, etc. But here's the key. You need to be able to diagnose the joints bilaterally. You need a Piper 3A or better, typically. What does that mean? You gotta learn lateral medial pole. You gotta learn how to read an MR. You can't trust the med radiologists. You gotta use someone like me. Or learn from us, learn from Dr. Piper. So, I think we're gonna go into this. I think we got enough time. This is a little bit deeper on the T-scan EMG link for those that have never seen it.
The T-scan EMG link explained. T-scan 2D, relative force percentages. T-scan 3D, relative force percentages, shown in 3 dimensions. The graphical interface, very important to keep that up. Quadrant view, separating anterior from posterior, anterior green red, posterior orange blue. Immediate complete anterior guidance development. Canine to canine, front circuit, front teeth. Premolar back circuit, back teeth. ICAGD is used to accomplish disclusion time reduction therapy. ICAGD is an occlusal adjustment procedure used on patients with stable and adapted joints. The T-scan studies relative force per unit time. Force on the y-axis, time on the x-axis. First force contact, indicated by A. All teeth forcefully coming together, indicated by B. Excursion begins, indicated by the C line.
Remember, we're adjusting excursive movement.
Posterior is no longer engaged, indicated by the D line. Time from A to B, occlusion time, OT. The amount of time the patient clenches together, B to C. Disclusion time, the amount of time it takes for posterior to disengage and anterior to engage, C to D. The timing is coincident between the T-scan and the EMG. Notice the A line. The simultaneity, the B line. These 2 instruments are synced in 3,000 of a second increments in turbo mode. The C line. And the D line. Always use turbo mode when performing DTR. Concentrating now on the EMG side of the link. Typically the temporalis and the masseter muscle pairs are studied. Red, in this case, temporalis, green, masseter. The bio-research, bio-EMG comes in 4-channel and 8-channel units. Depending on which unit you have, determines how many muscle groups you may study. Typically masseter and temporalis are all that are studied. An example of a right excursion. The center force icon, the kite, shows graphically in a given instant as to where the average forces are in the arch. Provided that the operator properly places the T-scan sensor between the 2 central incisors. Notice the center of force icon not moving between the B and the C line. At the C line, the patient makes the excursion to the right. The red represents the percentage of force touching the anterior teeth in the excursion. The blue, the working, posterior. Notice the blue working, persistent on the graphical interface. This is hyperfunctioning of muscles and mastication. Thus, this patient's disclusion time is long due to the posterior working and balancing contacts, slowing things up. Notice the hyperactive muscles on the right upper of the EMG graph. TAR, MMR, and MML are very spastic. After treating the right excursion, notice the center force icon. Things are slightly left. In MIP, that will be treated when we work the left excursion. In the meantime, pay attention. In the graphical interface, notice the red line is moving up towards the top of the Y or force axis very quickly. The blue is no longer there holding it up due to no more working interferences in the posterior. Thus, the exclusion time is greatly reduced. The patient hits initially on 9, 10, and 14, clenching between the B and C line. Notice on the right side on the EMG, the upper right quadrant. Notice how TAL after C is very flat, but right now it's very hyper. Right disclusion time begins at this point. Notice the C, at the C, the TAL, the contralateral opposite temporalis shuts down. Below 8 microvolts would be ideal. In this instance, things are not quite 8 microvolts. They're bouncing around 10 to 14 microvolts. Since this is a right excursion, TAR should be active and working, but not quite this hard. The working interferences and the balancing on number 14, 15 region are slowing things down. Thus, the disclusion time to the right is long. After treating the right excursion, notice that the patient still hits heavily on the left side initially. During the clench, look off to the right in the EMG data. Notice the muscles aren't as hyperactive during the clench as they were pre-DTR. The patient is getting ready to go off into the right excursion at the C line. Notice TAL shutting down rapidly and just past the C line, way below 8 microvolts. This is a good sign. Look how short the exclusion time is as well. Once again, using this right excursion as an example. Light blue representing right posterior contact, red representing right anterior contact. The goal is to get on the anteriors and off of the posteriors quickly. Light blue is represented on the graphical interface. Look at the yellow arrow pointing to the right on the graphical interface. Notice as we circle the working interferences on the 3D. These working interferences are primarily what are hyperfunctioning the muscles.
Time is shorter. The muscle activity is less.
After completing the ICAGD procedure on this right side, the operator would proceed to accomplish ICAGD on the left side, thereby completing the DTR therapy for the patient.
So how do you know when to do this? How do you know when it's the right time? You know, we're not supposed to touch teeth irreversibly, right? Remember? NIH stance and all this stuff? They're 100% correct. Except they don't know about measuring joints and how those hinges influence that. So I propose that we start measuring the joints themselves. Dr. Piper alluded to stable class 1 angle teeth, right, the setups and the angle classification. We had normal joints, we had stable and adapted, and we had unstable and maladaptive joints. Remember the 3 categories? Well, if I have an unstable and maladaptive set of joints, 1 is all it takes. One of the 3 table legs being jacked, I'm not touching that occlusion ever. If I prove with scans that I have 2 stable and adaptive joints, and some dentists muck them up with ortho movements or bridge work or crown work, you know, here's the NIH telling us that we're not supposed to alter occlusions. We do it every day with a typewriter. Think about it. We're basing our occlusal schemes on ink ribbon. So back and front teeth timing, it matters relative to the allodynia, the cold. FDH, the 5-second ice water squish, remember? I said 9 things I can't practice without. I saw 2 hands go up when I asked who uses ice water. I use it all the time, every patient. 2 things, pulp testing, all sorts of stuff. How much cheaper is ice water than the damn endo ice, for example, by the way? Now, is that all I ever use? Do I still use endo ice for endo, pathology and diagnosis? Of course, but I use this for occlusal things all the time. Look at him wince. Think this guy's comfortable right now after that squish? So along the way, Dr. Piper taught me these things. Sorry. And he forced me to reconsider. He's sitting here, I'm starting to learn from him, and he and I started getting together, and we should remember, we both have this like ethical thing going on, I guess. It's like, I want to protect the patient. I'm seeing that he's helping my people. I'm seeing that it's not about the money. It's not about chopping up joints. It's about, here's the numbers, here's the proof, and here's another thing. Of all the patients I've ever shared with him, there's only 1 patient where I got a report back where the only option was surgical. Out of, I don't know, 100-ish. Don't know the exact number. So all the other patients, let's say there's 199, there was a surgical and a non-surgical option. So he makes the patient own their problems. So do I on a lesser level. If I can't handle it, it gets sent to someone like him, who there is no one else like him. So DTR versus the ICAGD. I beat that to death. I don't want to bore the audience. But here's the point. It's flawed. We're talking just teeth and the trigeminal nerve. What's missing is the disc, the eminence, the presence or absence of adhesions, the sympathetic and cervical sensory inputs. Remember, we got layers, man. We've got dozens, sometimes dozens of layers. And
Different
just
highway,
profession.
different place, different geography, different neurology. So where do you have pain right now?
It's all in here, through here, the back of my head, and these muscles under here are all kind of tensed and tight.
Try to move your head that way and now this way. Is that sore?
Mm-hmm,
Tight?
yes. It's
Always
sore.
that way?
Yes. 7.5.
Really? Is it everywhere? Front, back?
It feels more like the back and then right through in the front teeth, but a lot in the back.
Below, is it?
No.
It's already in. Looks like a mosquito bite.
A lot down here is mostly where that's getting me.
But how about the back on the left side?
No.
So the back on the left side before was, you told me 7.5 5
Yes.
minutes ago. So now it's reduced
Yes, it's more, I feel it more up in,
to the front.
mhm. But I feel it a lot right in this front area. The bottom is worse.
But before we injected you,
Mhm.
it was everywhere.
Yes.
We're cervical, sympathetic, trigeminal. So cervical is neck. Sympathetics also come from the neck, and that's why I just blocked it this one side. Trigeminal is the cranial, the fifth cranial nerve. That's the things that dentists know. And that's like, it innervates the muscles of mastication, most of the joint. Okay, but a lot of times, if I give that block, all of a sudden this feels a little bit better.
Mhm.
That's because a percentage of this is from the neck.
Mhm. It's more down here, and I don't know if it's given that sensation back there, but it's more just like in this area right here.
So compared to 15, 20 minutes ago pre-injection,
It's better.
much different.
Yeah, I don't notice anything over here, nothing on the top. It's just like, it feels like in this section here.
On the left side. How's the face on one side or the other?
It's feeling better.
Both of them,
Mhm.
0 to 10.
Maybe 3,
So it's even better.
yes. Yeah. The
Okay.
head feels a little bit looser.
So it's fair to say that probably half of this pain up here is coming from down here,
Probably,
but it's referred. See what I'm saying?
yes.
Like if you get on the forums and you start listening to all these people complain, one of their big complaints is tinnitus, ringing in the ears. Guess where that's almost always coming from?
And that's another thing, I have ringing in the ears and I don't hear them right now as bad.
So did you have it this morning?
Mm-hmm.
Do you have it right now?
Not as bad as usually, no, it's very little.
You guys get it, right? It's like there's a lot of neck going on here.
Make the patient.
This side completely gone, cold sensitivity. This one's still there, but it's mostly to the front.
Yeah.
And the pain levels, you said 3-ish on both sides now. Yeah, okay.
Never touched your trigeminal. How do you explain that? These are online. Most every video that's in this presentation, patients are watching these as we speak. They're expecting this from us. So, what does that mean? I don't have a lot of time, but I'm trying to put some Excel sheets together and trying to track this over time and maybe write a publication. It needs to get out there. That tongue reference, I believe that was an oral surgeon that couldn't get wisdom teeth numb, and he hit the great auricular and that knocked it out. How cool is that? How many in this audience have had problems getting a lower molar blocked? Oh, come on. Should be every hand. So, other pain layer inputs. Trigeminal, cervical, sympathetic. We beat that to death today, I hope, but I want you to remember that. We learned about the fifth cranial nerve. We learned a little bit about cervical, sympathetic, and passing at best, correct? So what are the diagnoses? I'm looking for diagnoses. I'm putting these numbers together to try to give these people answers, because no one can give them answers. And without knowing what's wrong, how can you possibly treat it? You can't. So, Migrainous, osteochondral growth defects, you can see that on imaging. You know, heartbeats, first thing I look at. On CT, as a matter of fact. Dr. Piper taught me how to do that. Tumors, fibromyalgia, what the hell's that? It's a catch-all. Just like, so fibromyalgia is medicine's catch-all for pain, TMD's dentistry's catch-all for pain. That's pretty pathetic. We can do better. Let's get off typewriter, for example. We can do better than that too in everyday dental world. Edema. Edema, we know what edema is, but we don't think about it much in practice. We do after, say, an extraction or an implant placement or, right, a laceration or a contusion or something. But, you know, example, real quick. Kid walks in, 8 years old, 9 years old, let's say, thumped out, the bolts their front tooth. What's the first thing we all, let's say it wasn't a bolts, let's say they cracked it, can't really see a pulp exposure, half the clinical crown's there, but you can see, oh my God, we're almost there. So you're all puckering up about endo and worrying about telling the mom about it might turn dark and you're gonna bond it, maybe you'll rebond the tooth, the piece if it's not shattered. And, you know, you're worried about endo, right? You know what I worry about? I worry about that too, but I also worry about what the hell happened to their chin. By definition, macro trauma, macro, okay? Thump. Micro is what we're taught in dental dogmatic world. The bites off, the rub, too much this, that, and the other. Too much, the CRCO slide. That's micro trauma. I'm talking macro. So why? What's the point? You hit the chin, what's connected up here? Soft tissue, ligaments holding cartilage in place. What happens if you tear those ligaments? You cause a growth center problem, potentially. An osteochondral growth defect. How can I know that? CT combined with MR. Thank you, Dr. Piper, for showing me that after looking at 25,000 TMJs, 30 plus years, and surgically accessing 7,000. Necrosis. I don't want to get into that world. I'm sure Dr. Piper could talk about some stories about how an avascular necrosis never happens in the condylar head, but it can happen in every other bone in the human body. Neurological issues. That's a big one. Tendinitis. So what does that mean? What about sympathetic tone? You know, the point is, degeneration. What's the diagnosis? Effusions. What's that mean? Fluid buildup in spaces. Soft tissue spaces. You know what edema means? Not just the swelling. Edema could be swelling in bone. How do you see that? MR. We need to learn how to do that. You affect the hinge, you throw off the way the door hits the jamb. Simple, biomechanical. And I'm not saying that's in everything, but that's something we should all be taking into consideration. Remember I mentioned the anterior open bite? Guess what that girl or boy might wind up presenting with years later? An anterior open bite resultant of an osteochondral growth defect and a discal problem that no one ever caught. And here we are, throw them in an ortho, and that fails. They get a revision. They'll open up, they'll go to college, they'll come back. Oh, we got any orthodontic surgery, and no one's looking at the damn joints. So, and then all of a sudden, let's take that a couple of decades down the path of the hard tissue never grew out all the way. The soft tissue genetically programmed to be so big, that space is crowded. What have you got? Sleep apnea. You got someone having a problem with sleep. What about the sympathetics, the pineal gland? What about the autonomic influence on that? Who's measuring that? Who's publishing on that? The sympathetic. Infections. What about rheumatological factors too? Et cetera, et cetera, et cetera, et cetera, et cetera. Is it all about muscle? No way, absolutely not. So the CNO thing, what is the CNO thing? As I said earlier, it's a teaching center, a small one. But it's more, the dream is it's a network to connect health professionals so that we all talk to one another and we learn to put numbers to things and we speak amongst ourselves and we try to improve things and we improve the curriculum and we're dynamic. We don't always say it has to be this way or that way. We prove with numbers that it can and here's the result and from there it grows. And then we help those patients. So we learn how to objectively measure the layers to arrive at a set of objective diagnoses before proceeding with treatments. So there's 4 levels. I'm going to go through this real quick. CNOF, that's something people do online, home study. They're learning about dogmatic occlusal principles. CNO1, they come to us in Arkansas. Where I live is a very affluent area, very easy access. X&A, that's Walmart headquarters. Think about how many companies Walmart does business with. measured anterior guidance yields a predictable occlusion in patients with stable and adapted joints. Towards all through CN01, we start bringing in the imaging thing, the CT and the MR thing. You gotta have stable and adapted hinges, man. Do not do that DTR thing without it. Get you in trouble. Then all of a sudden, NIH is 100% right. You just go for T. Be asking for it. CNO2, one-on-one in office training. One of the CNO docs on the board goes to your practice, in your practice, with you and your patients, and watches you do this stuff, make sure you know what the hell you're doing relative to teeth. Because we're dentists, we gotta work with teeth. It would be really cool if we could figure out how post-ortho, post-restorative, to make sure in a patient with stable and adapted joints that we're not gonna have one of these layers kicking in at the time of the occlusion. CNO3, this is the big one for us right now. How to determine if your patient possesses stable and adapted TMJs, an introduction to 3D imaging. Then we force you to go to Dr. Piper if you want to follow our ways, if you want to learn from us. To his imaging course and his entire curriculum if you'd like. You can go at any sequence, do whatever you want. But the point is, if someone's trying to go through the CNO path, remember the website, Patients Find a Doctor? We list them based on exams, certification, written and oral. And by the time you go through the CNO curriculum, you know how to read your own damn MRI and CT, at least well enough to know that there's something you shouldn't touch. So back and front teeth timing. It's a dental or a tooth allodynia. It's not just cold, it's not just hypersensitive teeth. Man, I wrote a 90-page chapter on hypersensitivity. Remember how much time I spent on that crap? And all these names we've got for it, CDH, cervical, this, that, and the other. I mean, come on, dentinal, but said blah, 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 blah. Right? And there are all these theories, hydrodynamic, abdonoblast, transducer. I'm not saying they're incorrect, I'm saying they're incomplete. There's other layers involved with that too. And that stuff's starting to tip into the medical arena. You know what I'm saying? I mean, the body's connected. Nature could care less about boundaries. So, let's have an alternate theory for Dr. Kirsten's DTR theory. Let's use Dr. Piper. He mentioned it. He buzzed through a slide. It said SIDO, sympathetically induced dystonia of occlusion. An alternate theory. Autonomic neurological inputs from both the periodontium and the interpulpal tissues pick up the proprioceptive. Remember A beta? Remember I mentioned A delta, C, A beta? A beta is proprioceptive, okay? Super fast myelinated, and it's in the dental pulp. We weren't taught that. I'm gonna show you literature references. That's a huge thing. You have what the hell is a nerve fiber doing in the compartment syndrome that is the internals of a tooth, where it's looking for touch and feel? Think about it. You're in a vault. What the hell's it picking up? What's moving in there? Proprioceptive tap-tap between opposing posterior teeth in the excursions. That's an alternate theory. What's my point? Remember I talked about flex your teeth? Go read the chapter of the textbook. I don't have time to get into this. The bottom line is, I think this is a combination of trigeminal, Kirsten's theory, and Piper's theory on the SIDO. That's the best I can do thus far in my head and my experience of hundreds and hundreds of people doing this. What's going on? The tap-taps. Think proprioception. Sympathetics, interpulpal A betas. Look this up. If you join the CNO, this is one of the required readings. We give you a list. Kubo et al., these guys, Japanese researchers, 2008. Basically, they were like, we just took fMRI and we proved that the A beta talks to somatosensory cortex. Remember that sensory homunculus, that crazy thing in neurology back in school? With the leg, the penis, the arm, the nose, the big lip? Remember that? The tooth thing, they're actually tracking intrapulpal, and that's one of the sympathetic autonomic things going on in the body. So I'm going to buzz through this a little faster because we've got other things to do. So what is anterior guidance dependent on? This is important. Remember this, if nothing else, from this whole lecture. Remember anterior guidance, we're all taught that basic principle in occlusion. We practice that probably every day, correct? Teeth, right? Duh, canines, front teeth, back teeth. What about two condylar heads? There are two parts of the three-legged table. There are two hinges on the door. The door is one bone, it's the mandible. What about two eminences? I mean, what the heck? That thing right there, upside down hillside, Doesn't that condylar head kind of rake up underneath it? Doesn't that separate the back teeth? How can you know if you can't tie this in and can't put a number to it? 2 discs. We already talked about the different thicknesses. Posterior band versus intermediate versus anterior band, etc. Presence or lack of adhesions in both TMJs. What's an adhesion? It's kind of like a sticky scar buildup. How the hell are you going to see that? You're going to hear it? You're going to feel it? Touchy-feely. Think subjective. Palpation, subjective. Put numbers to it. MAGD versus ICAGD. Measured anterior guidance development versus Dr. Kirstein's immediate complete anterior guidance development. I'm the one that keeps pushing MAGD because MAGD means that I'm thinking 3 legs to a table. I'm thinking about the discs, the eminences, the shape and condition of condylar heads, what that may be doing to the way the teeth interdigitate, and what that may be doing to the neurology of the system. So we're objectively measuring these things. We're looking at them. Are they broken down? Are they intact? Is it unilateral, bilateral? What the hell's going on? Is it rheumatological? Is it cervical? Is it sympathetic? Is it trigeminal? Back and front teeth timing. Again, allodynia, cold. And Dr. Piper already defined this, but I will stress this point. Pain arising from stimuli which are not normally painful, such as the intake of cold fluids in the oral cavity. Okay, the ice water switch. So what is MAGD? As I mentioned, we're thinking joints and teeth. Measuring anterior guidance development, an occlusal adjustment procedure. It's the same thing as ICAGD, but we're considering the hinges. And I don't want to beat it to death. There's a neurology behind that. I've seen it hundreds of times. Their pain abates. Well, does that mean their pathology is gone? Will they recapture their disc? No, they won't. Sorry. Once you tear those ligaments, guys, that's done. That's toast. I don't care what they taught us about splints and recapturing or what the tensing will do. Doesn't happen. Start imaging and you'll see for yourself. Do it serially. Just like you would do. Question, who in the audience would do endo without a PA? Or nowadays a CBCT? Let's just say PA. Who would do endo in this audience without an x-ray? Nobody, right? So who in the hell would touch the occlusion or mess with a TMD patient without looking at the MRI and the CT of the joints? Ask yourself that. Think about it. I'm not trying to be harsh. I'm being serious. It's malpractice. Medicine gives us one joint, albeit probably the most complicated in the body, but we can't even get that right. So the MAGD procedure, or ICAGD, if you want to call it that, if you're not considering joint status, is out of their habitual MIP, not fully seated. I literally never look at CR. Go look at some videos Dr. Piper and I have done. We'll talk about what CR really is. They're on ViewMedi, they're on YouTube. Minuscule excursive adjustments. What does that mean? Well, it's the adjustment on that crown or that filling that someone did, or that orthodontic movement, that tipping that was never quantified at the end. Remember, the orthodontist, hell, he's just looking to see how it looks. Is it past one angle? Are their front teeth touching? She's out of here. Get that bonding off. Give her a bicycle. Minuscule excursive adjustments, subtractive in the posterior and or additive in the anterior. Consideration is given to the joint structures as well as the teeth. In appropriate patients, I stress appropriate patients. And how in the heck do we find the appropriate patients? The imaging. So MAGD biomechanically and physiologically adapts the appropriate patients. I keep straining, appropriate. Static and dynamic. Static, dynamic, occlusion to the status of their objectively confirmed, relatively stable and adapted TMJs in a measured and objective manner. Why is MAGD important? Because it's one of these layers. If you don't know about it, you're going to miss it. It doesn't mean it's everything. It's not a catch-all. It's not a cure for TMJ, TMD, whatever you want to call it. It's not. It's one of many layers. If the patient's really lucky, that could be all that's going on. I've seen a few of those. Nowadays, I see less and less because I see complicated stuff. Think about it. If they flew from Australia, you think they're maybe a little obsessed with their problem, they can't find help. How many people do they fly over to get to? Australia, I think we've had 4 times. Try Indonesia. Try South Africa. Try physician from South Africa. 28 hours. 5 jumps. And Dr. Alfred was there. I don't know if he's in the back still. Terry's in the restroom. Okay, unlike ICAGD, I'm beating it to death. A tool that creates a reproducible physiologic change is a layer in appropriate patients. Think 4D, think timing. So I want you guys to think about vital signs of medicine. Beats per minute, right? Think about all these things in medical world that they're doing with timing. In dental world, what are we timing? Maybe it doesn't matter. I mean, how can you time anything with the ink grip? Are you looking? Is that objective? Are you putting a number to that? It's not. It's completely subjective. So think like I call myself a dental engineer in my own mind because I'm trying to put numbers to this stuff. And the more I learn, the less I know. And I'm like frantically looking for numbers because I represent the patient. I sit up here representing all those people that can't find help. And I represent the patient because they're sick of the dogma. They're sick of us swallowing whatever we're taught at whatever institute or whatever. I want numbers put to it. And who am I? I'm just one guy. But I'm the guy that they're looking at 2,000 times a day. And we're ramping it up. And we're growing. Again, in patients with relatively stable and adapted joints. What does that mean? You got to use the MR and the CT. That's how I predict. Thank you, Dr. Piper, for teaching me how to do that. MAGD requires the T-scan. I need Microsoft Word. I can't use the typewriter. Can't do this stuff. Not even close. I don't care what brand you're using, what technique you've got. It doesn't work. Objective, reproducible, and recordable. Can you record in your network, if you're computerized, which I'm assuming most everyone is, their occlusion? When you insert their crown, pre-op, post-op? No, you can't. I use a T-scan anytime I do more than a simple, actually, I use lasers for occlusal fillings a lot. They're very minuscule. Think air abrasion, size of a hole. No anesthesia much of the time. Something really tiny, I probably won't use a T-scan, but anything that I'm cutting, prepping, a class 2, I'm taking a burr 2, it's big enough. I'm taking a pre-op T-scan and a post-op. I've got a record of what the hell they were like before and after. If that's the inciting event, I've got a record. I got my rear end covered, and I've got their rear end covered because I want to know if it was us. Because guess what? Remember, 20% fly in or come in, whatever, however they come, TMD or facial. 80% are just normal patients. I see 2 to 3 CRIPS patients that I can identify in my local patient pool a year. Local, you got them too. So what the hell is a mid-course correction? Anyone ever heard that term? Jay Levy, 2009, theoretically wrote about this in a paper. Teeth as sensory organs. He was, Pete Dawson gave him some award for, 2009's best idea or something. Basically, let me show you what it is. You guys see that? So here you are biting down. This is the summation of all that's happening at that instant back in time. So let's call this a trail of breadcrumbs. This is where all the average, the sum of all the average relative force percentages are at a given time. So at that instant, that center of force icon, let's call it the kite, it started up here. You guys get that? And then it tracked over time. They were clenching. Then they're trying to make a right excursive movement. It's going east, then it goes, what, southeast? And then it goes northeast. That little kink right there, that's a mid-course correction. So let's look at it real time. Watch. Kink. Now, what if I told you, in my experience, hundreds of people, remember I'm the DTR guy that people see online, and I've written about this stuff, Rafula, Robert and I are the guys on the DTR. That's probably more important than the timing. And how can I see that? I can't see it with ribbon. I can't. You ask the patient how it feels, or you feel the tooth. I mean, come on. Touchy-feely subjective, or do you want something objective? You knock that thing out, they've got stable and adaptive joints. If this is the primary layer to their problem, bam, gone. Allodynia, spasm, if that's it. Now, how could that be introduced if they've got really good joints? Orthodontic movements, non-measured dental insertions, restorative, things that we do. How many states, okay, another question. In this audience, I'm sure you got people from all over the country and maybe outside of the country. How many states or jurisdictions allow dental assistants to place sealants? Mine do. You think I'm letting my dental assistant or my I do let Boone do it. You know what? Boone knows how to use a T-scan, right? The sealant can cause this. That's extreme, but it can. I've seen that a few times. I'm really pushing it there, okay? But it can be that minor. So, MAGD confirmed via EMG. So without the EMG, I can't really know. Without the T-scan, I can't really know. I use them both. It's not a sales pitch. You guys do what you want. But these are some of the tools that we use to put numbers to things. So how do we time and objectively measure the occlusion? We don't use ribbon. Okay? Do you guys know this? This is important. 12 to 38% accurate relative to force and time. Ribbon. There's literature references. Yet, we all use it. And everyone before us used it, and our mentors used it. And we'll retire using it, most of us. It's subjective. It's a typewriter. Reading tea leaves. To adjust the patient's occlusion in 2018. What's the T-scan? About 95% of the literature. Look it up. So, iatrogenics. I already alluded to this. I'm going to speed it up a little bit. We talk about ortho and restorative, iatrogenic introduction, right? Artificial, crowns, fillings, sealants, implants, ortho movements, bridges. So, people flying in from wherever they're flying in from. Let's say they've got really good stable and adaptive joints. What do I oftentimes see as being the iatrogenic thing that's jacked with them? A lot of people will not like this. Zirconia. You can't adapt zirconia, man. It's tougher than enamel. Remember, this system likes to adapt primarily in the teeth, joint teeth. If you've got zirconia against enamel, you can't wear one into the other, and maybe CNS doesn't like that, and it keeps pushing and keeps pushing. So when I'm making these adjustments and the excursions and what have you, I'm grinding on someone's zirconia much of the time. Remember, they come from everywhere. Don't say my community or my town. That's why this is profound. I have a patient pool that comes from everywhere. I don't want to beat it to death. In patients with objectively confirmed stable and adaptive joints, the interactions between opposing teeth in time, measuring time, directly influences a major neurological mechanism influencing the muscles of mastication. Add or subtract. You learn when you learn this stuff. Depends on the teeth and the joints. You bond canines sometimes to get on the anteriors faster and better and get rid of the mid-course and watch the muscle shut down. The disclusion time is basically, this is Kirstein's theory. We can talk about this if you guys ever come and learn. We're talking about a timed anterior guidance is the point, okay? We're timing the working movement, the balancing movement, the protrusive movement. Key points MAGD, measured anterior guidance development. I want the disclusion time less than half a second. The OT, which is the time from first contact to all teeth intercuspating, less than 0.2. This is based on Robert's research. And I want efficient pathways, minimal mid-course corrections. I highlight that because that, in my world's experience, is more important over time. So think 4D dentistry. Think 4D time. Fourth dimension. Are all TMD patients candidates for MAGD? Absolutely not. TMD, again, is multifactorial. Other treatment and diagnostic palliative options that we use in our practice. MRI scan-based mandibular repositioning. Dr. Piper taught me that. There are cases where we can take a non-surgical route whereby we bring them down and forwards, not based on EMG and tensing, but based upon scans. I want to have as much of that damn cartilage that's displaced anteriorly between condylar head and glenoid fossa. The least amount of forward posturing. The girl in the beginning video, guess what I did for her? MRI scan-based repositioning. She had CRPS. Remember? She has neck issues too. She has a plethora of problems. She's a local. I see her all the time. I rarely use splints. No one's going to like that in this audience. Honestly, how many splints a year? 2, 3, 1? If even that. Cool. I give them a diagnosis. Botox to palliate. Usually if they're getting Botox from me, that means they need to see Dr. Piper or someone like him. Neck blocks. I use that. It's a diagnostic thing. And sometimes I've even seen lasting help for people. Depends where you catch it. It's temporal. It's timing. All things in life are about timing, right? All things in medicine are about timing. In dentistry, we don't really talk about it. We need to start talking about it. Low-level laser therapy, biostim, that helps some too. More of a palliative thing. And I refer. I learned that I need to refer. There's a quick deal on the MRI scan-based repositioning. Remember, I use CEREC. 98% of what I do with prosthetics is built in office with CAD/CAM. And I can very precisely, within 40 microns, bring it back to where I want based on a bite guide through numerous bite positions and numerous MRI scans. I figure out what's going on. And by the way, MRIs are not that expensive. Don't tell me my patient can't afford it, insurance won't cover it. They probably won't cover it, but you know what? You negotiate, learn to negotiate with your imaging centers. $600, $800, $900, not that much money. How much is your splint? Based on dogma. What if I told you your splint could make them worse than the 2 hinges? You got another condition of the soft tissue. CT's not enough. Splints, when I make them, I always have an MRI first. Because I want to know what the hell the discs are doing. Are the ligaments torn? How do I know if ligaments are torn? The discs are displaced. Botox, based on EMG readings. I don't just give Botox based on some recipe cookie cutter thing I learned from Dr. XYZ. I base it on EMG readings. Neck blocks. Thank you, Dr. Piper, for teaching me that, to help diagnose them. There's a general dentist sticking people in the neck. Do it all the time. Biostim. Refer. There's a chiropractor. This guy was from England. Works in Buckingham Palace. There's a hotel right there. Sauvignon, what was he? The wine guy? Super awesome guy. He wants to come back to me. He says, I was better for a while, now I'm not so good. And I'm like, nope, you're going to St. Pete. Why? Because I knew he wasn't quite stable and adaptive, but he wanted me to try what I did, and he signs here after I make him own his problem. So, plural. And then Dr. Piper and I work together quite a bit. So, how do we objectively diagnose? How much time do I have left? Anybody know? 15. Okay, thank you. Neural occlusion screening. What are we measuring? At present, this list, it's in your slideshow. I'm not going to go through every one of them. We're putting numbers to everything on that board. Okay? And a lot of this stuff comes from Dr. Piper's teachings. A lot of this stuff comes from Dr. Erskine. A lot of this stuff, a few of these things come from me. So remember I mentioned the proficiency and certification thing. By the time you go through CNO, you know how to put numbers to those things. Does it matter? I guess it does. We're helping people. Not everyone, but a lot of people, in ways that are not taught anywhere else. There's an exam. I'm going to speed through this because I want to show you guys another video or two. Basically, we test along the way. We make you pass. If you don't pass, you do it again. A lot of literature reading, a lot of textbook reading. We outline. We give you a path. CNO 1, CNO 3. I do those both in Arkansas. So, this is where I wanted to get to. So let's go to some practical stuff at the end of the lecture. If we can get online. Oh, come on, guys.
Can you show us, like, can you open for us? It's deviating to that one side. Does it hurt at all? It's not hurting. But you can't open it, it's going off to one side, right? Try it again for me, sweetie. Okay, great, thank you. Oh gosh. Hey, that's the worst of it. You're on it less. Okay? What was it? So, like, mosquito bite? For as far as ouch goes, that's the worst of it, okay? I can always add a little bit more. So I'm going to have you just sit here 5 or 10 minutes. Don't let that freak you out.
Hey, look.
Is it changing already?
I think I'm curious. Maybe not.
Let me see. A little bit. It's a little better already. It's only been about 30 seconds. How crazy is that? Huh? Yeah, let's give it a few minutes.
You're trying to do a root canal. That would ruin your day if you couldn't get them done. You couldn't get in.
Holy spit.
Wow.
Awesome. Okay, let's get to work. Let's get her out of here.
Something's wrong with our internet connection. All right. You guys get that? I filmed that when I was building this. This is just, oh yeah, I better put something in there. This isn't uncommon. Here's another one, 3 minutes long. Let's pray we can get down the line here. Jaw spasm, neck block. Patients are seeing this stuff.
What's going on? Just a few minutes ago, we tried to go in your mouth. We tried to use a prop. Can you hold your exit? Right? And you tried to place that, and what happened?
As I opened it, I just felt this started hurting, spasming pretty bad.
What was it exactly?
It started up here and it just started coming down.
To the corner?
Yeah, and right now, when I try to open my mouth, it spasms right here, like in this area.
Yeah. So you can't open well right now?
No, it hurts.
It hurts. And you're partly numb, aren't you?
Yeah, yeah.
Can you show us where you're numb on your lip?
It goes all the way here. I can feel this side, but from here, I don't feel it. And down here.
How about your tongue? Do you feel any strangeness on your tongue?
Half of my tongue is numb.
Right, so you got the normal block.
Yeah, like I feel this numb. But up here, I feel it, everything. But yeah, I feel all this.
Okay, so, and we did fillings on you a couple weeks ago, and we didn't have any problems like that.
No.
What's the pain like right now? Is it sharp? Is it?
It just feels like if I were to open it wide, my jaw would just like pop out. Like it hurts.
Sometimes the ligaments are loose on the disc up here.
Mm-hmm.
Let me look here. Pretty helpful.
It's like JVA everything.
Mm-hmm.
Your jaw's screaming clear. You still feel the spasm?
Oh yeah.
It's pretty bad.
It just as much as I can open my mouth.
Show me.
Because then it hurts.
Got it. And it's only on this side. You don't feel it over here, do you?
No. It's just this part right here.
Guys, the relevance is the JVA, joint vibration. It's done on every patient that walks in the practice. So I just go to the computer, pull it out. I'm not saying JVA is the bomb, okay? 50, 60% accurate in my experience. The less damage they are, the more accurate it is. The more damage they are, the less reliable it is. But I'm able to look at that in seconds. I have a record. So I've got a quick idea of, does she look beautiful or does she look like she's jacked? Well, she looks jacked on the JVA. Does that mean I scan her? No. We're in the middle of doing her fillings. That'll crush your hour, won't it? And she leaves hurting in her lower jaw after you give a shot, right? Dysesthesia, that's not good for business.
You all right?
Yeah.
Wasn't too bad, was it?
No.
It's like getting a Charlie horse.
Yeah.
That's exactly what it is.
As soon as it just opened my whole entire thing, oh my gosh, the pain just went down.
Yeah. What's interesting is that spasm, this thing that's going on in your jaw, that injection should stop it.
Okay.
In about 10 minutes. Okay, so just be patient with me. I apologize.
No, that's fine.
All right, so does it feel any different yet? Can you open yet?
Yeah.
The pain gone?
Yeah.
Look at you.
Just a hair.
Just a hair, right?
Just a hair.
So it's already better.
Yeah.
It's only been, what, a minute? Not even a minute. But what that injection does, it catches the angle of your mandible, and that's where the master insert. Look at you, you're more normal now.
It's just the hair. I can feel it.
I tell you what.
Earlier.
Yeah. So that'd be a big difference, isn't it?
Yeah.
In about 15 minutes since you injected, what do you think?
Yeah, I feel a lot better. It's gone.
Gone?
Yeah.
Pretty normal?
Yes. Yeah.
So the injection, when we injected it, within a minute or so, can you tell me what percentage better?
Oh, at least 50. And then now it's, since we wait a little bit longer, it's just completely gone now.
Is your earlobe now?
It's a little bit. Yeah.
All right, so if you feel anything, let me know. In summary, how do you feel now?
A lot better.
Are you back to normal?
Oh yeah. Oh yeah.
Yeah, the normal numbness, you still got, now you got ear numbness too though, right?
Yeah.
Pretty cool. If you can pull this out like you do any kind of infiltration, it's not that hard to learn. You better take your time with it and all of that. Compartment syndrome, we're almost done. This one might be a little long. Let me just summarize this. This girl's told by an endodontist she needs a root canal. This girl presents with an anterior open bite. This girl's 30, wealthy husband, likes to be pampered, and she's sick of hurting on number 31. So, pull out a greater auricular neck block, this chronic pain that she's had. Did we catch it pre-necrotic? Remember vasoconstriction from the sympathetic inputs, excessive, can cause necrosis over time, resulting in edema, hypoxia, etc. Dr. Piper lectured on that well. If you get them fast enough, oftentimes, this will stop it. Guess who didn't do the root canal? Think about that for a minute. So think about all the times that we have patients that come back in after we work their lower molars and they're chronically sensitive. So this FDH thing, or whatever you want to call it, allodynia, whatever you want to call it, the ice swish, it's starting to kind of all make sense. All of a sudden, there's something in your armamentarium, a little bit of anesthetic costs you what, $2? And do we charge for that? If I'm in the middle of treatment, I don't charge for that. Like those 2 girls we saw earlier. If I'm sitting there trying to diagnose and eliminate, say, the need for endodontics, yes, she gets charged about $200 for bilateral neck blocks, $200-300 on these 2 something. So, take home, dental allodynia. This one's important. This one I think will play. Shorter.
So you and I, we met a while back and we cleaned out a cavity in your bottom right molar, and it was really close to your nerve, and it was bothering you. It woke you up at night,
Yes.
if I remember right? So we wound up cleaning out that big cavity. We did a crown, the same day kind of crown.
Yes.
And it's been, what, a week or 2?
It's been about a month.
It's been a month now. So tell us how it feels.
When I have hot or cold, I can just feel pain.
Yeah.
It's not the intense pain like it was before.
Sure.
But it lingers.
It does linger. How long?
I can feel it a couple minutes after I have something to drink.
But it's not woken you up at night or anything like that since then, right? You haven't had any spontaneous pain, it's just thermal. It's a hot and cold response. Has it spread throughout the face, or is it just generalized in that area?
It's just generalized in that area.
And you can tell it's that too?
Yes.
So today we're going to try to numb a different kind of nerve that's coming in from your neck. And we're going to see if we get any kind of different response. You understand that, I've already talked about it. Theoretically, it's going to help open up blood vessels that might be constricted, and the living tooth is dying from lack of oxygen. If that's why it's starting to go south, that could be helpful for you. Because it seems like it's on an edge.
Yes.
Right? Has it gotten worse, or is it still?
It's about the same.
The whole past month, it's the same. It's not getting better, it's not getting worse. Okay. So what about chewing? What's chewing do?
I haven't had a lot of pain with chewing.
Good.
It's just more the heat and the cold.
Not in cold. Let's try. That's ice water.
Okay.
If you would switch it for me for about 5 seconds. Tell me what it does.
I just feel like a radiating pain in the back of my
Yeah, on that right
side
side.
of my jaw.
And it feels like that too, doesn't it? Is it gone yet?
I can still feel it. It's not as intense,
Okay.
but I can still feel it.
So that's typical. So over the past month, you've been dealing with like an iced tea or something.
Yes.
It's like, it zaps you and it goes slowly away.
And I still have a dull pain right now.
And that's been 20 seconds.
Yes.
Okay.
Oh.
Yeah. Right. So describe where? Front, back, left,
On
right?
the sides, actually.
Side of that tooth?
On both sides of the tooth, and then I can feel it going down.
Downwards. And it's isolated that one thing. And give me a 0 to 10.
That one was pretty bad. I would say that was like a 6.
Okay. Elsewhere?
No.
No big deal. Okay.
I do grind my teeth every once in a while.
Yeah. That's a sign of a TMJ problem. Which we do this to help people figure out what's wrong with them. TMJ problem. So it's been about 4 minutes. What do you think? Do you feel a difference right now?
It just feels more relaxed.
Your face does?
Just like down here, I can feel a little bit.
The neck?
Yeah, a little bit numb.
And maybe the border of
Yes,
your handle?
yeah.
Does it come forwards or just to the corner?
It's just the corner.
Gotcha. Yeah, give it a switch and see what we got. Is your earlobe now by chance on that side?
Not really.
Okay. 0 to 10.
That's probably a 3. Not anywhere or 2, maybe.
Swish it really hard. Make sure
Like a 3 or 4.
it's definitely.
It's less, but I can still feel it.
So it's percentage less.
Yes. So I still feel it, and I feel it more on this side than I do on the inside.
On the cheek side.
On the cheek side, yes.
Got it.
It was very intense on both sides before.
Got it.
So.
Oh, really? Interesting. So the inside wall towards tongue
Yes.
is less sensitive. The outside walls may be a hair better, but
Yes.
kind of the same. Let's start going right. All right. All right. Good job. High five. She's thinking. I love it.
Feel it, yeah, coming up.
It's creeping.
Yeah.
But Brandon's gonna switch. See what you got already.
I would say that's probably a 2 to 3.
Wow, it's going down about 10%.
Yeah.
Crazy.
I think I got all the way up to 6, though. So,
Do you feel the angst being done over here?
yeah, more than I did before.
Yeah.
But it's,
He's not crazy. It takes some time.
yeah. Well, I definitely have sensitive teeth, too. So, I mean, just
In general.
like when I get my teeth cleaned and
But
stuff
do you
like
right
that.
now?
No.
How cool is that?
Yeah, it's very cool.
Yeah, give me a 0 to 10.
That's like a 1.
That's like no big deal, right? And we haven't touched, no shots inside your
No.
mouth. Can you please point to where we injected you?
Right around here.
And an hour ago, you were swishing ice water and you were
It's
a
a 6.
6 out of 10. And now you were a,
1.
what do you think of that?
It's pretty cool.
It's pretty wicked.
Yeah, it
So you
is.
can go buy some Sensodyne?
No. I don't need it.
Exactly. Thank you very much.
You guys starting to get it? These are cervical inputs, sympathetic inputs. These are not what we were taught in school. It's not what we practice every day. By the way, I'm almost done. The CNO playlist can be found. It's on your PDF. You click on it and you pull it up in Adobe or whatever you use. There's literally probably 100 hours of stuff you can watch. It's all free. I have 420 videos uploaded. I've been busy. 250 of them are public, so you're welcome to watch. And we have playlists. There's a CNO playlist out there, so if you're just looking for, like you're a professional, you don't want to look at the whole soap opera, which can be a soap opera sometime with the patients, what they see, go to the CNO playlist. And you'll see Dr. Piper there numerous times. Or look on ViewMedi. ViewMedi, every time we send a video out, we get about 700 to 900 hits a day. Remember, physicians and dentists only. So, Dr. Alfred in the back, that was him here last year. Dr. Abram, who couldn't make it today, I can't believe it's her. That was the South African MD. We actually helped her, remember? First time in 8 years. You can find her video on the CNO deal. Thanks again, Dr. Piper. Really respect you. You're my Yoda.